Good morning. My name's Adam Capek. I'm one of the anaesthetic consultants at the Glasgow Royal Infirmary. It's about 6:30 in the morning on a Saturday morning. You can see it's a lovely day in the middle of August, and I'm just taking the dog for a walk before I go into work. I'm on call today, and I thought I'd just bring you along on the ride of what an on-call for me is like. So essentially what I'm going to do today is I'll be working on the labour ward in Glasgow Royal between about 8 and 8 in the daytime. I'll actually be present in the building, and I'll be working with one of our junior doctors, our junior anaesthetists, and obviously working with the obstetricians who look after the pregnant women in labour, and the midwifery staff and everyone else that works in the labour ward. Basically to keep everyone safe. That's looking at pain relief in labour, and that's also looking after people if they need to come to theatre for, say, a caesarean section. And then I will be able to come home at that stage if everything's all right, but I'm still going to be on call overnight, so hopefully I won't be taking you into the hospital overnight, but there's a chance that I might be talking to you in the middle of the night as well. We'll just cross that bridge when we come to it. So anyway, I thought I'd say hello. I will next speak to you once I'm in the hospital. The dog's somewhere in the background. I better go and check where he is. I can just about hear him somewhere. Yeah, I'll see you later on. Cheers. Hi, it's me again. It's coming on for about 9 o'clock. I'm now at work. I'm in my scrubs. I've got a face mask here as well. We're all kind of wearing face masks if we're in any communal areas because of COVID. And obviously then when we're going through to operations, we'd be wearing them anyway. We are just about to bring a lady through for a caesarean section. So we've handed over with the obstetric team and the anaesthetic team that were on overnight. There's a few things rumbling along. In labour ward, there's a lady who's very, very premature, who we are currently trying to stop her delivering, just to give the baby a bit more time in the womb, well, as long as it can possibly have. But we're also about to bring a lady through for a caesarean section. Now, she is a lady who, we call it a breech delivery, where essentially the baby, rather than being head down, the baby is bottom down, so it's trying to come out bottom first. You can deliver these babies vaginally, so they can come out the normal way essentially, but there is slightly more risk that they can get a bit stuck because their head's obviously the widest point as they come out. So the rest of the baby could potentially deliver and then the head gets stuck, and that is quite a risky situation. So both for the mother and for the baby. So in most settings, in that situation with a breech delivery, so a baby coming bottom first, we do a caesarean section. So we're just going to get ourselves set up to do that. The lady will have what we call a spinal anaesthetic. It's very similar to an epidural. It's a wee jag in the base of the spine. Essentially, we put a wee bit of anaesthetic just around the spinal cord, and we can freeze up her tummy. We also make her legs very, very heavy with that. So we're able to operate and deliver the baby, but she'll still be wide awake, so at least she can still be there when the baby's born. And it also means her partner can come in as well, whereas if she was having a general anaesthetic, we wouldn't let the partner in. So there's lots of benefits to that. It's also a wee bit safer, all things being equal, for the mum and for the baby. So normally we do a spinal anaesthetic for a caesarean section. So we're just going to go off, get ourselves ready to do that, and I'll let you know how it goes in a wee bit. Cheers. Hi again. I'm just going to give you a wee update on how the day's going. It's about 12:30, so I'm getting a bit hungry and it's time for lunch really. We've had a pretty good morning. So the caesarean section that we went off to do went very, very well, you'll be pleased to know. The baby came out and was crying and all happy. And mum and dad were crying, but they were also crying with happiness. So that is definitely one of the good bits of our job. When it all goes well, working on labour ward is a fantastic place to be. We've also done an epidural for a lady, so we've only just put that in. Now with epidurals, I'm hoping to run you through them in a bit more detail through the day, but we obviously run epidurals for pain relief in labour, and they're great. We put a wee tiny tube in the back, and we can essentially just keep running an infusion of anaesthetic just in and around the spinal cord for the duration of the labour. So whether it lasts 2 hours or lasts 12 hours or 24 hours, we can ideally still keep ladies comfortable for that whole time. Now it takes about 20 minutes or half an hour or so to build up. So in that time, in 20 minutes to half an hour, we'll go back and see how she's doing. We can always give her a bit more anaesthetic into that if we need to. But as I say, I'll try and run you through them in a bit more detail. I might even show you one of the trainers that we use with our junior anaesthetists to help get them some practice in inserting epidurals, and that will explain it a bit better. So that's how we're getting on. I'm going to try and eat something, and then we'll go back and see Our Lady in a minute. Cheers. So here we are again. I'm back in my little cubby hole, which is one of the prep rooms that's just off one of the theatres on Labour Ward. It's about 1:30, coming on for 2 o'clock maybe. I've had something to eat. I've been back to that lady that we put the epidural in. She's nice and comfortable now, which is what we want. So hopefully just through the course of the afternoon, she will have a baby. I thought I'd talk you through actually what epidurals are. There's something that you hear lots about, certainly in the press, certainly if you go to medical school, you'll learn lots about them. But what exactly are they? Well, they are one of the main forms of pain relief that we can offer to women on labour ward. We know that having a baby is probably the most painful thing that any human being can experience. So being able to offer pain relief is an incredibly rewarding part of our job. Some women don't want that pain relief. That's completely fine. Some women find that delivering in water, so having a water birth, can help. Sometimes simple pain relief, things like paracetamol, can make a difference, or using gas and air or laughing gas, which we more commonly call Entonox in the hospital. That can really help. Injections of things like morphine can help, but certainly an epidural injection can also make a big difference, and that's something that we offer pretty well all of the women that come through here. Of that, maybe about a quarter of the women take us up on that offer and they're keen for an epidural. So how do we do it? Well, I've got a model of a spine here. This is a spine obviously with the skin taken away. Now, if you look from the back, you see these spinous processes running down the back. They're the bits of the bone that you can feel at the base of your spine. If you run your finger down your spine, you'll feel those bits of bone. Now, in the middle of all of these bones is the spinal cord. You can just about see it in the middle there. And coming off the spinal cord are all of these nerves. Now, those nerves are what's coming round onto the abdomen, into the womb, down into the perineum. So if we're able to bathe those nerves with lots of anaesthetic, then we can make the woman much more comfortable and make a big difference to her labour. How we do that? Well, we can pass a needle between these bones, and we want to pop it into what's called the epidural space, which is just outside the sac that's covering the spinal cord. Now, that sac is full of lots of fluid called CSF, or cerebrospinal fluid. So we don't want our needle to go into that fluid. We want it to sit just outside it. So through those bones, then sitting in that epidural space. Now, once our needle's in that space, we're able to insert a little catheter in there. So a little tube like this. Essentially, we can run it through the needle up into that space. And when that wee catheter is sitting there, it can just stay there as long as we need it to, really. And we can put anaesthetic down that little tube. There you go, I need 3 hands for this. We can put our anaesthetic down that little tube, and that can last as long as the labour lasts, whether that's another hour or whether that's 24 hours. That will sit there. We obviously stick it down on the skin. So I will run you through the process of how we do that. But to identify that little space, we've obviously not got X-ray vision. We use what we call a loss of resistance technique. Now, what I mean by that is if we try and inject into something fairly solid, so whether that's bone or whether that's a ligament or even just tissue, we can't really inject. So if we try and inject either air or saline, which is what we call salty water, into a ligament, so something tough, you'll see there, if I just cover up the hole on that needle, I'm not able to inject. It just keeps bouncing back on me. But as soon as that needle tip passes through into that little space we call the epidural space, suddenly I'm able to inject, because now it's in a space rather than something solid. So as we pass our wee needle through the skin in the back, between those bones, between the spinous processes, I'm constantly trying to inject. And as soon as that tip goes into the right place, suddenly I'm able to inject. I stop pushing the needle forward and I can put my wee catheter into that space. So I'm going to show you now how we do it on this model. So this is one of the models that we'd use if we are training our trainee anaesthetists how to do epidurals. So first of all, I need to have a wee feel of the back. I'm going to stand up because it's a bit easier to do this standing, I find. So I'm going to have a feel for the bones in the back. I obviously can't see them, but I can feel them. And I can feel the space between them. I'm just going to pass my needle in. And once I feel it's kind of sitting in those ligaments, I take out what we call this reintroducer. That's just to stop any bits of tissue getting in the needle. And I can now start trying to inject. And as I slowly advance this needle forward, I'm constantly trying to inject. And at some point soon, there we go, suddenly I can inject there, do you see? So I know that now I'm in the right spot. Now, I've got just a little guide there. I can now pass my catheter in through that needle, which will just run inside the space. I should say that while I'm doing this, if I was doing it for real, I would be completely sterile. So as sterile as I'd be if I was doing heart surgery. So I'd be wearing a gown, I'd be wearing a mask, I'd have completely scrubbed my hands. So I pass that wee needle into the right spot, that catheter through the needle. Now I can take the needle out, but that catheter is still sitting in the right spot. I can hook that up to a drip of anaesthetic. That anaesthetic is going to supply all of those nerves that are coming out of the spinal cord, supplying the uterus, supplying the perineum, and they're hopefully going to keep our lady as comfy as possible for the duration of her labour. So that's how we do an epidural. Cheers. Now, while I had the model out, I thought that I would explain to you also what's the difference between an epidural anaesthetic and a spinal anaesthetic. You might remember earlier on I mentioned the lady that we were bringing to theatre for a caesarean section, and she didn't get an epidural, she got a spinal anaesthetic. Now it's a very similar process, it's still a wee injection at the base of the spine, but we find that a spinal anaesthetic tends to work a little bit better for an operation, something like a caesarean section. It comes on a bit quicker and it comes on a bit stronger. Now from the point of view of the woman, it's pretty similar, it's still an injection just at the bottom of the back there. But there is a subtle difference. Now, I mentioned to you with our spinal model, with the epidural, we're trying to stay just outside that sac that is covering the spinal cord. Now, that sac's filled with all that cerebrospinal fluid, or the CSF, and we're trying to stay outside that spot for an epidural injection. It means the epidural just has to sort of work its way across towards the spinal cord, towards those nerves, so it takes a little bit of time to come on. But it does mean we can put that catheter into that place, that wee tube into that epidural space, and we can then run it as long as we need. For an operation, which we know is going to last about an hour or so, we don't need to worry about it lasting for a long time, but what we want is as strong an anaesthetic as possible. So with that, we use a much smaller needle. So you can see the difference here between my epidural needle and my spinal needle, which you can barely see on the screen there, it's so thin. So we use a much smaller needle, and again we pass the needle through between those bones in the back, between the spinous processes, but this time we intentionally go through that epidural space. We now go through the sac covering the spinal cord, or its posh name is the meninges. So if someone gets meningitis, for what it's worth, it's an inflammation or an infection of those coverings of the brain and the spinal cord called the meninges. But we're passing this through the meninges, and we're now actually able to take a sample of some of the fluid, the CSF, that's covering the spinal cord. And not only getting a sample of that fluid, we can now inject into that space, and we only need a tiny amount of anaesthetic, but because it's essentially acting directly on the spinal cord by just going straight through that fluid, the lady, or a man, because we sometimes do it for other operations like knee replacements or hip replacements, they get very rapid anaesthetic. Much smaller needle, the same process, but we pass it in this time until we get that fluid back. We inject in there and they get much more rapid onset of the pain relief. We don't leave anything in there, we don't leave one of those wee tubes, so we know it will only last about an hour or 2 hours most. But for an operation, for something like a caesarean section which lasts about an hour, it's absolutely perfect. It's a bit more straightforward because essentially we can just keep pushing that needle in until we get the fluid back. Whereas with the epidural, remember we were having to use that loss of resistance. We were doing that injection all the way. So that's what the difference between a spinal and an epidural is. in case anyone ever asks you. Thanks. Good evening, everyone. How are you doing? It's a fair few hours since I last spoke to you. It's now, I'm sitting in my car, I'm just about to head home. Looking at the clock, it's 20 to 10 in the evening. We've had a pretty busy time of it since we last chatted. We've done a couple of more cesarean sections for babies that weren't in desperate trouble, were just a little bit stuck and weren't really coming out the right way. We've also done a forceps delivery, so again, that's for a baby that just was a bit stuck and just needed a bit more help coming out. Now, from an anaesthetic point of view, we've done all of that with both spinal anaesthetics and epidurals, like I've been explaining to you. Now, at about 8 o'clock this evening, I was just handing over to the team that were coming onto the night shift. As I mentioned, I'm on call tonight. I'll be on call from home, and I can be called in if there's further emergencies. But there's 2 other anaesthetists in the building who will be looking after things unless they want a bit of extra backup. So anyway, we were just handing over. Everything was nice and settled. We thought we'd finished everything we needed to do. And then one of the midwives came and knocked on the door of the office and said there was another emergency. There was what we call a cord prolapse. Now, that basically means that as the woman's in labour, rather than the baby coming out first, a bit of the umbilical cord comes out instead of the baby. Now, that's a very, very dangerous situation for the baby. That means the baby's still inside the mum, but the cord is now hanging outside the mum. The blood stops flowing potentially through that cord because it gets very, very cold, and it can also get a bit trapped. The baby at that stage is entirely reliant on the blood through that cord. So very, very quickly, you can have a very, very bad outcome for that baby. So it's a real emergency on labour ward. So what we did, we rushed the lady round to theatre. We quickly gave her a general anaesthetic. Now, that is the quickest way to get her in a position for the obstetricians. So that's the specialists in looking after labouring women, for the obstetricians to do a caesarean section. So she got given a general anaesthetic. Ultimately, we had a really good result. The baby came out. Often the baby gets a little bit of the anaesthetic as well. So the baby was a little bit sleepy for a minute or so, but then started screaming. The mum's nice and comfy. We've now woken her up. She's delighted. She's met her baby. We've had a really good result. It's a really, really great thing to be part of. I'm not saying that I wouldn't have minded if they hadn't come and knocked on the door at 8 o'clock when I was just heading home for some dinner. But to be honest, that's a great part of my job. We've really helped. We've not just helped a woman, we've not just helped a baby, we've helped a whole family have a great outcome there. So now I am going to head home. The phone's still on. I could get called back. We'll just have to wait and see. But anyway, I'm going to go home, have some dinner, and then hopefully get to bed. Cheers. Good morning. It is now Sunday morning. It's about 7:15, maybe 7:30. I'm back out walking the dog. This is Dougal. Here you go. I'll leave him be so he can have a run. And it is nearly the end of my on-call. I'm officially on call for another half hour or so. It was a pretty good night. I got called once just to give a bit of advice, but thankfully didn't have to go into the hospital, so I've basically had a decent sleep, and I'll class that as a definite win. So what have we learned in the last 24 hours? Well, it's been pretty varied. It's shown you a lot of the huge positives of my job, particularly my work on labour ward. Some of the technical skills, so doing the spinals, the epidurals, obviously putting in drips and things. Some of the rapid decision making we have to make. So that would be, for instance, that lady that came around with the cord prolapse just at the end of the evening last night, who we had to very, very rapidly put off to sleep, give a general anaesthetic to. And all the other skills that are entailed in that. So as part of a general anaesthetic, we have to put a tube down into the airways, down into the trachea, to help the woman breathe. We have to give lots of fluids. We have to manage whether she's going to need any blood or not. So all of those other skills are sort of intertwined in what the anaesthetist does on labour ward. Now, I don't just work on labour ward. Most anaesthetists, we have several roles. So labour ward work is part of my role. I'm off today, obviously, and then tomorrow is Monday, and I will go back into my other role, and that's my role in the main theatres, in general theatre, where I do a lot of work with the surgeons who do what we call upper GI surgery. So that's surgery on the esophagus, on the stomach. So tomorrow, as different as you can get from delivering babies, we'll be removing someone's esophagus. We call it an esophagectomy, and that's a chap who's got cancer and needs that to be removed. So again, hugely rewarding work, hopefully a curative operation, a very, very big procedure. Rather than lasting an hour or so, which a cesarean might last, this operation will probably last about 7 hours, and brings in other skills. So for instance, sometimes doing these operations, we have to be able to ventilate one lung and deflate the other so that they can operate up in the chest. Either way, he'll get a very big wound in his tummy, so that needs us to really focus on the analgesia. Again, we can do spinals and epidurals and things to help the pain for that, but then we definitely put the patient to sleep afterwards. So it's an incredibly varied job. We work with a huge team of people. We certainly don't work in isolation. So there's the surgeons we work with, the obstetricians on labour ward, there's the midwives, there's anaesthetic assistants who are specialist nursing staff who are highly trained in assisting us in our job. I absolutely love my job. What are the downsides? Well, yesterday, you can see it's still nice and blue skies behind me. Yesterday I missed a trip to the beach, unfortunately, with my kids, my wife and my sister. They sent me photos of them eating ice cream. It looked lovely. But you know, I'll take my job, I'll take the highs and lows, and I'm ready to go again tomorrow morning. I hope you've enjoyed this. Cheers, good luck, bye.